There are three major salivary glands: the parotid, sublingual, and submandibular. However, scattered all over the oral cavity are smaller, minor salivary glands. All these glands help keep the oral cavity moist and safe, as we shall see shortly. Sialoliths are calculi that form usually in the salivary duct. Sialolithiasis is caused by a salivary gland stone, or calculi. Its composition is calcium, magnesium, potassium, and ammonium. It may be asymptomatic, but it may be also palpable. The submandibular is the most common site, and the most common symptom is pain on salivation. So you can see on the picture, you can actually see the sialolith emerging from the duct, and you can also see it on a occlusal radiograph since it's radio-opaque. We spoke about Sjogren's syndrome in DH 366. We will now review the disease's manifestations overall and take a deeper look at one of the cardinal signs of Sjogren's, which is xerostomia. Sjogren's is an immune-mediated disorder, and the symptoms are listed on the left-hand side of the slide. So you can see there are many oral symptoms: dry, cracked tongue, sore throat, burning throat, difficulty talking, difficulty swallowing, difficulty chewing dry food, change in sense of taste and smell, increased in cavities, mouth sores, and cracked lips. And all of this really stems from the fact that there is a severe decrease or almost no saliva present in the mouth. So we are going to take a look at probably one of the more cardinal signs of Sjogren's, which is xerostomia. While xerostomia is a sign of Sjogren's, there are other causes of xerostomia. First, let's review the role of saliva in the oral cavity. So what the saliva does is to lubricate, protect, and cleanse the oral mucosa. It aids in chewing, swallowing, and talking. If you've ever had a dry mouth and tried to talk or tried to chew or swallow, it's virtually impossible to do so. It supports and facilitates the sense of taste. It protects the teeth against decay. It protects the mouth, teeth, throat against bacterial, viral, and fungal infections. There are enzymes in saliva that actually help protect the mouth against any kinds of infections. So what is xerostomia? Simply put, it is a lack of saliva and salivary flow. The signs and symptoms are insufficient pooling of saliva. We all know as clinicians that when the patient's mouth is open for any extended period of time, there will be saliva pooling. Some people more, some people less. In people with xerostomia, there's nothing. There is no saliva. In fact, the tissues will become really, really dry if the patient remains open for a long period of time. It does cause caries, cervical caries. The tongue will look red or parched. The patient will complain about difficulty swallowing, eating, or talking, and change in taste sensation, and burning mouth pain. So here on the right-hand side are some of the possibilities for common causes of reduced salivary flow. So the patient may not have a systemic disease like Sjogren's, but they may be on some types of medications that will also cause them to develop xerostomia. Also, electrolyte loss, things like dehydration, things like lifestyle, smoking, excessive caffeine intake, and alcohol abuse generally contribute to dry mouth in a patient. And some patients, for whatever reason, that really can't be determined, just have a reduced saliva flow. So let's focus on the oral complications because obviously that's where xerostomia is most affects. Oral complications are increased caries and periodontal disease. So if you take a look at the illustrations of the pictures on the right-hand side, you can see where there's those dark areas on that upper picture. Those are all carious lesions. But notice on the lower right-hand side where the caries are occurring. For most people with halfway decent oral hygiene practices, caries do not occur at that cervical area or the interproximal cervical area. So that's kind of a clue that something is going on with the patient's saliva flow. If you see caries in these, usually in these areas where the patient is, able to, even with minimal oral hygiene, keep that area clean. Patients will get mouth sores. They are more susceptible to candidiasis, and they can get angular cheilitis, cracked lips, tongue dryness, and difficulty, obviously, eating, chewing, and speaking. The oral complications are widespread. Often the oral symptoms are detected before the patient is even aware of, having a condition or having xerostomia. For the most part, the treatment is palliative. We try to ease the symptoms. So here's some of the things that you can recommend to your patients who have xerostomia. They need to get regular checkups and keep really good oral hygiene. That's really important to prevent those caries. Avoid sugars, sip water or drink water with meals. The water with meals is a good idea because that gives you some lubrication to eat. The sipping water for most patients is not a real, a lot of patients object to that. I've had patients tell me that, I drink water all day and then I have to go to the bathroom all day. Avoid caffeine. Caffeine can be very drying to tissue. Make sure they lubricate their lips. Sometimes the use of a humidifier in the room will help. And in order to stimulate any, whatever function the salivary glands still have, the use of sugar-free stimulants, particularly ones that have xylitol. Xylitol is one of those naturally occurring sugars that will not promote the growth of oral bacteria, and indeed, seems to have some sort of a protective properties to it. Also, it's good for diabetics because it does not cause sugar spikes in their blood sugar. Of course, there are over-the-counter things that you can do. We all know about the different types of mouthwashes and toothpastes that are possible for people who have dry mouth. But there are also commercially available saliva substitutes. Now, these are if you look at a saliva substitute, it's kind of greasy looking. It's very viscous, but it tends to stay in the mouth a lot longer than water would. It tends to coat the mouth and keep the mouth feeling like it's more hydrated. So these are commercially available. It's over the counter. The one thing I learned is that these saliva substitutes, while they're not prescription, are usually kept behind the counter at the pharmacy. Patient will have to go to the counter and say, I would like, a saliva substitute, and generally they can get it without a prescription. So that's one possibility, rather than the continuous drinking of water. There are prescription medications, and we very rarely prescribe these. These are probably given by physicians in the case where, it's very severe, or they have a condition like Sjogren's, where they are not going to make saliva. They'll need something to stimulate the saliva glands. So we'll now talk about infections. Endemic parotitis is caused by the paramyxovirus. So endemic parotitis is also called mumps. You can see some of the clinical features, about a 14 to 18-day incubation period, usually pain, or headache, myalgia, muscle pain, malaise, low-grade fever. parotitis. The parotid gland is the one that's probably most effective, in 30 to 40% of the clinical cases. And interestingly, up to 20% of the infections are asymptomatic. So mumps is a highly preventable disease with vaccination. There are a multitude of benign salivary gland tumors. While they are located in the major salivary glands, they may arise from the minor salivary glands. Pleomorphic adenoma is a benign tumor. However, it does have the potential to become malignant depending on the duration of the lesion. So the longer it is not detected, the chances are, the odds are it may become malignant. The risk factors are smoking, alcohol abuse, and previous head and neck radiation treatment. Please note the location of this particular tumor. Being located unilaterally helps to distinguish it from a torus. As there are a multitude of benign salivary lesions, there are many malignant salivary gland tumors, and we're just going to cover a couple of the more common types of malignant tumors. Mucoepidermoid carcinoma generally occurs in the parotid gland. It's probably one of the most common salivary gland cancers, occurring in about 30 to 35% of all salivary gland cancers. It's usually a low-grade type of tumor. Acidic cell carcinoma, usually in older individuals, no gender predilection, represents only about 14% of the parotid gland tumors and about 9% of the total salivary gland carcinomas in all sites. In 50% of the cases, the clinical appearance is a benign lesion. So it looks like it's benign. Of course, I don't know. The one on the right-hand side is pretty extensive, and that would probably indicate more like a malignant lesion. But generally, initially, it'll show up as it will appear as a benign lesion, and then will have to be biopsied to determine exactly what, if it is or if it isn't cancer. So this concludes the lecture on salivary gland tumors. If you have any questions, once again, or comments or issues, please do not hesitate to let me know.